Our second speaker is Hank Abrams. Hank is a pulmonologist and critical care doctor. I think he's retired from full-time clinical practice to devote himself to efforts to reform the healthcare system. In that regard, he's the board president of the California chapter of Physicians for a National Health Program, which is a group that advocates Medicare for all. And we're very happy to have him here as our guest, Dr. Abrams.
Thank you so much. It's a very great pleasure to talk to this great audience and to hear Jeff's comments. I think they were very interesting. Well, Jeff mentioned the third rail, I think. There are two third rails, actually, so I guess each one is a 1.5 rail. But I'm going to mention the other one. Excuse me one sec, and I will have, yes.
There should be a presenter view on your slide.
There isn't on this version, but there we go. Okay. So the other third rail is morality, and it's been impressed on me many times that you should never try to talk to people about morality. So I'm going to do it because I think that the place where each of us starts and where our country should start in asking ourselves what kind of healthcare system we want for our country, it's our system, is our moral view of what kind of society that we would like to have. Do we think that healthcare is related to the security of our families, ourselves, our communities, the people that we love? Do we think that better healthcare is an American value that's worth sacrificing for? So I take the position that it is, and all through my career, it's been a strong motivator in terms of priorities that I have taken. So I think that in looking at the current healthcare crisis, you need to ask yourself, and I can't convince someone who takes a different moral stand to adopt my moral stand, but I think that when we find that we're talking at cross purposes, sometimes it's because one person thinks that healthcare is solely an individual responsibility and that they take care of themselves and it's not their job to take care of other people. And then I take the view that it is my job, that's why I became a doctor, but I also feel responsible for involving myself in the education, in the well-being of my neighbors, and the quality of life in my community, and the conduct of my country. So that's my moral position, and I want to be very clear about that. So the healthcare crisis involves, I think, a lack of clarity, because in the health reform discussion, we never really had a chance to discuss this question. We jumped into a discussion about legislation and costs, and really it started out as a horse race. Which bill would be up or down, which bill would be voted into effect. The second question is, what kind of actual healthcare delivery do we want? How do we want our doctors to treat us? How do we as doctors want our professional training to be employed? And the third, of course, we've already talked about economics. So let me run through some of these things with you. A little difficult for me to read. Okay, I can do it better here. So when we talk about healthcare, such issues as these come to mind. Medical education. In our medical education system, Dr. Lebowski already referred to the enormous debt that medical students experience, and I think that that's a real problem that has to be addressed. We don't want people to make career choices based on economic decisions which drive everybody into the more lucrative forms of practice, when the great lack at the moment is to have more good primary care doctors. And so I put choice of practice here because choice of practice is the community that you practice in, the kind of population that you see. And as you'll see, the theme in much of what I talk about is that these things are money-driven, and really they shouldn't be. The effective use of the profession, the healthcare professions, and it's not just doctors, it's nurses, it's physical therapists, it's nurse practitioners, etc. The effective use of that profession as an economic and social resource needs to be put on a proper footing. After all, the profession is supported by the educational system that we put in place, and the cost of maintaining that profession, again, comes from our pockets. And most people who go into a healthcare profession go in because of a desire to be of service. It's a tremendously enjoyable, challenging, satisfying, problem-solving, intellectually stimulating career. But really, the reason that people are allowed to pursue this career is to be of service to their community. I think when we talk about the healthcare crisis, we also ought to look at professional integrity autonomy, that is, the ability to make a decision based on what's best for the patient, the patient's autonomy and the doctor's autonomy. We need a patient-doctor controlled healthcare system, not a money-driven system. And many of my colleagues in medicine are experiencing profound dissatisfaction with the current state of the healthcare system. Our patients and their families are sometimes well satisfied and trust us, but sometimes not. And part of that, I think, is that the money-driven nature of the system has curtailed the ability of the doctor or the nurse practitioner to spend adequate time with the patient. We don't get reimbursed as doctors for having a long but absolutely necessary discussion with a patient or family who are facing a difficult situation. We don't give them time to ask all of the questions that they want to ask. We don't give them an opportunity to come back in a few days and ask the questions that they forgot to ask during that first discussion. It takes time. And as an intensive care doctor, it became clear to me that a lot of what I was doing was helping people to have an end of life that fulfilled as best as possible the hopes that they had, the values that they had, because we're all going to die. But if I couldn't give people enough time, then they were angry, they were frustrated, they would seek another doctor, and there would be some of the duplication of services that Dr. Lebowski referred to. So I think that this tremendous overconsumption of care at the end of life can be reduced a great deal if doctors and patients simply had more time to talk with one another and to plan ahead and to discuss alternatives and to learn to face the future. People are incredibly brave, and many people don't want to have their lives prolonged when it doesn't make sense. It's not fulfilling their values. It's not making them, it's not empowering them to do things that are satisfying to them. At that point, many people want to be kept comfortable. They want to be surrounded by their family. They want to be cared for. And there's much that doctors and nurses can do to provide care, but it doesn't involve waste. It doesn't involve unnecessary technology. And so I think that a lot of what occurs is simply the result of people not having had the discussions and sometimes turning to the procedure, the life support that wasn't really explained, and in the end it's futile, it wasn't really wanted, but the patient wasn't given an opportunity to participate in that choice. So other aspects to thinking about the kind of health care that we want are to think about the quality of care, the outcomes that we're trying to achieve, and of course, cost containment. So my approach to healthcare reform is, this is getting a little bit repetitious because it's morality, it's, as Dr. Lebowski has said, to think about access and quality of care. And then thirdly, after we create our wish list and define what our values are, then to talk about the cost, and we need a system that's economically sustainable. So we can set the cost at whatever level we would like to set it at. The question is, do we have the ability to then control those costs? And perhaps we would decide that we want to spend the same amount of our GDP on health care. Perhaps that's too much because it's taking it away from other things that we want to invest in. Or perhaps we would be willing to spend more. But it should be our decision. And I think that we have sometimes felt powerless to affect that decision, and we really haven't been asked that question. We've been told that we need cost containment, and I believe that we do, but we haven't really been asked how much are we willing to pay for health care. And I think that each of us needs to think about that. Other aspects of the economics are fairness and, of course, the consequences in terms of whether more dollars will get us better health care and whether more dollars will take it away from other things that we need. And the last thing that we should allow to come into the discussion after we think about the morality, the quality and type of health care and the economics is the politics. And I think that in the healthcare reform process in 2009 and 2010, the politics took over before we were ready for it. And people told us that we were going to have a choice of this bill or that bill. This would be included or that would be not allowed. But they were telling us. I don't think that we were really telling them. And I don't think people were screaming because their sense of morality was offended because we hadn't really had a discussion about what the moral choices are. So I think that we really got to approach the discussion in an unproductive way. The key elements of the Affordable Care Act, some of these have been mentioned. You'll get to keep your insurance whether you like it or not. You won't have a lot of choices to change if you're not satisfied with your insurance. The individual mandate is that you will be required to have private health insurance or pay a fine unless you're covered under one of the other programs like Medicare. There will be subsidies for the poor. There will be a state insurance exchange, which will be open to small businesses, self-employed individuals, and those who are not offered employer-sponsored insurance. But those exchanges won't start for another 3 years. There will be changes to Medicare. Dr. Lebowski referred to some of the difficulties. Medicare needs to be improved. Some of the change in the Affordable Care Act, I think, is a justifiable limitation on the amount that Medicare allows for what are called Medicare Advantage type plans. This is where you can choose to have certain things bundled into your Medicare coverage. But it's interesting that the sellers of those plans are paid a bonus, which is really unjustified because you could get the equivalent care through traditional Medicare for about 14% less. So that extra 14% for the country as a whole translates into large amounts of money that are paid as a bonus that really have not been earned, I would say, by the insurance carriers who sell the Medicare Advantage plans. The long-term care insurance provision is rather small. and I'm not going to speak about it much except to say that it might pay 10 or 15% of your bill for long-term care insurance. There will be new regulations on insurers, and immigrants are either restricted or banned. Even if you have documentation, you're a legal immigrant, you can't be covered by the Affordable Care Act for 5 years. So my impressions of the Affordable Care Act are that it's incredibly complex. The bill, as you probably heard, is 2,000 pages long, and very few people in Congress read the entire bill before they voted on it. There's much good in it. There's much that's bad and some that's really ugly. It does support subsidies for the poor, but it's unclear how well those subsidies are going to work. And my prediction is that the Affordable Care Act will achieve mediocre, expensive health care for some people that don't have it now, and it may prevent illness in some others. So for those of us who want quality, affordable health care for all, there's no rest for the weary. A little more on the morality of the Affordable Care Act. It's not universal. Dr. Lebowski mentioned this. It will exclude 25 million people, and it will foster underinsurance. Underinsurance is a problem that deserves considerable attention. Having coverage can mean lots of different things. If you have coverage, if you're working at if you're not extremely affluent, and you have to budget your expenses, and utilizing health care means that you have to pay the first $1,500, $2,000 out of your own pocket. And then for every doctor visit or every prescription, you have to pay an additional $20 or $25. That is a huge barrier to health care. So it's been a bit shocking to find out that the bankruptcy rate, even before the economy started to tank about 3 years ago, the bankruptcy rate in this country, which was quite high, was in the majority of cases a function of untenable health care expenses on the part of people filing for bankruptcy. And just 1 or 2 days ago, a study came out reporting that in Massachusetts, which has this state plan that began about 5 years ago and has enrolled the vast majority of the uninsured into their system, it doesn't look as though the bankruptcy rate has fallen significantly at all. So this is just pointing out that we need to recognize there's insurance and then there's insurance. And not all insurance is good insurance. Having underinsurance doesn't necessarily get you in the door to receive health care. It may be good in a catastrophic situation, but it may keep you from or present a considerable barrier to getting the primary care, which is so important. Another aspect of morality was the individual mandate that if you aren't covered under an employer plan or Medicare or Medicaid, that you will be required or fined if you don't purchase a defective corporate product. And that offends a lot of people, and offends me. However, the Affordable Care Act does subsidize low-income individuals based on need. Medicaid will expand, and Dr. Lebowski's referred to the fact that both access and quality for Medicare patients are difficult. And I wouldn't want to take away anyone's Medicaid card. I think it's absolutely necessary if a person has no alternative. But let's not fool ourselves into thinking that any of us would consider Medicaid to be first-class insurance. So we have, people who are sitting in the first-class seats, and we have people who are sitting in the economy seats, and then the Medicaid people are somewhere down below that, hanging on for dear life, trying to get a shred of health care here or there under very difficult conditions, difficult for them and difficult for their providers. I've said several times that transactions are too money-driven in the system rather than being made according to what's best for patients. And they will remain that way under the Affordable Care Act. And there's great burdensome administration which will persist. There will be no reduction in paperwork. The administrative waste that we could recapture if we had a more sensible healthcare system is $400 billion a year. It's about 1/6 of the national healthcare expenditure. And so because that will exist as long as we have private health insurance. If we converted to a Medicare for All type plan, which I will come to in a moment, that administrative waste would be reduced to 3%, from a very high figure to a very low figure. 3% is what it costs the Medicare intermediaries, the Medicare system, to make care available, to pay the bills, basically, for patients on Medicare. So 97% of the premium dollars collected by Medicare go to pay for the health care of the patients. In the private system, it's about 70%. Some say it could be 80%. The rest of it is wasted. So, under the Affordable Care Act, there will be about 25 million people that will enroll in private insurance through the exchanges, but much of that insurance, again, will be under insurance. Medicaid will increase. It could be a lot better than that. The uninsured will be reduced by about half, so there will still be about 25 million people with no health insurance. Premiums will continue to rise, and we see that every week in the paper. We see that an insurance company in California has raised their premiums to the point that seem unreasonable, and patients and the newspaper columnists and the state insurance commissioner are rolling their eyes and saying, how can this possibly be justified that somebody's premiums went up 30 or 40% last year, and this year they're going up 30 or 40% again. There really is no effective cost containment in the Affordable Care Act. And the annual health care expenditure per person per year, which is now about $8,000 for the entire country, will grow at a rate of about 6 or 7% per year. You all know that that will exceed the rate of inflation. Therefore, this is not simply an adjustment that's justified by inflation. So what are the models that countries have used for healthcare systems? There's the out-of-pocket model. The out-of-pocket model says, if you can pay for it, you get it. Pay at the time of service, cash down, and we don't have insurance coverage. Then the model that most industrial countries have used is some form of the healthcare social insurance system created in Germany by Chancellor Bismarck in the 1800s, based on a nonprofit, multi-payer, tightly regulated system. This is what's in place in much of Western Europe. Then the British created the National Health Service based on the ideas of Beveridge, and so he gave his name to the Beveridge model. The Beveridge model is socialized medicine, where most of the healthcare facilities and the providers are actually employed by the government. That is socialized medicine. I want to be clear that the single-payer movement in this country is not advocating a takeover of providers at all. We do insist that providers be converted to nonprofit status, as your hospital here is. We don't think that hospitals should be owned by corporations that are beholden to stockholders who are trying to make a profit. We think that healthcare is a service, but we do not think that the hospitals need to be taken over or the doctors need to work for the government. And then there's the Canadian model called the National Health Insurance Model. It's government run, it's a single payer. That is, all the revenues are collected by one fund, which pays all of the bills. But the care is privately delivered. It's not socialized medicine. What is our model? According to T.R. Reid, in his book, The Healing of America, and I really recommend that people read that. It's very entertaining, it's very informative. And T.R. Reid says the U.S. has elements of all four. For most working people under 65, we're Germany. That is, we have employer provided health insurance, the Bismarck model. For veterans, for the military, Native Americans, and I might add, the President and members of Congress, we're Great Britain. They go to a healthcare facility which is owned by the government. So we do have socialized medicine in that sphere. For seniors, we're Canada. The only difference really is that Canada, which invented Medicare, called it Medicare before the United States did, Canada went on to extend it to the entire population. It started in the province of Saskatchewan, and within a few years, it caught on because it made so much sense, it worked so well, and now every Canadian gets a medical card when they're born, and they just go around and see whoever they need to see, and they get very good care. It's not problem-free. No healthcare system ever will be. And it costs the Canadians half as much as our healthcare. If you have diabetes or you have hypertension or other serious diseases, you'll have an outcome in Canada that's just as good as, and in some cases better than, in the United States. And their life expectancy, their infant mortality rate, et cetera, is better than ours. And then we have the fourth form of healthcare, the out-of-pocket for 50 million people that are uninsured. We're Cambodia. So we can change healthcare. There is a lot of cynicism, there's a lot of exhaustion among people who have been trying to change many things in this country, but we can do it. After all, we're the ones who hire the people that vote for the bills, and we need to be a lot more informed. This is not a simple question, and I don't recommend a snap approach to it. People who want to change healthcare need to do some serious thinking. They need to educate themselves, and they need to become involved. But how will healthcare change in this country? The idea of letting the market work it out is a completely ridiculous idea. Dr. Lebowski referred to the fact that it hasn't worked over 30 years. But one of the reasons it hasn't worked is that it isn't a market. There is no market for health care. And a famous economist who won a Nobel Prize wrote a paper a number of years ago proving to his colleagues in the world of economics that healthcare does not function like a market. So why would we expect the market to solve the problems of healthcare? The reason it doesn't function as a market is that you don't have the buyer and seller meeting in the office or in the clinic with full and equal information, and the buyer can't walk away from the transaction. They don't have a choice. That's why it's not a market. It's not like shopping for a purse or shopping for rutabagas. It's very different. We can change healthcare through incremental change, and that's what the Affordable Care Act tried to do, in which the government covers the poor and other selected groups, and everyone else is required to buy private insurance, even if it's not adequate insurance. And of course, the insurers, in the process of trying to regulate them, we have to then deal with their interests as private, profit-making corporations. And that's where this huge amount of lobbying money is spent to protect not our interests, but their interests. So we're in direct opposition, and therefore the incremental approach allowing us to continue to have a private health insurance system, in other words, corporate insurance in this country, will never allow us to have cost containment and to have a moral healthcare system that will provide the kind of healthcare that we want. So we're left with what we need is social insurance. It has to cover everybody. It has to spread the risk among the entire population. And the model of this could be improving Medicare and expanding it to cover everyone. So how can we change healthcare? We have to become informed, and then we have to do something. We have to utilize that privilege that we have as citizens in a democratic society and vote intelligently. We have to organize. We have to become a force. We have to join organizations. We have to make our voices heard. And we have to defeat our opponents when it comes to the referendum or the ballot box. So I urge you to pay attention to the California single-payer bill. I haven't talked a lot about how single-payer would actually work, but I've mentioned that it would be a 100% universal system. It would be publicly funded. It would be privately delivered care, and it would be publicly accountable. The system would be set up in a way that we would be in control of how the decisions are made. And of course, we would listen to experts. There would be a process for appeals, but the system would be answerable to the people for whom it exists, us. So the California Senate bill is the California Universal Health Care Act. It's passed the legislature twice. It's been introduced again by Senator Mark Leno from San Francisco and Marin County. And the first hearing in the Senate Health Committee will come up on April 27th. Governor Schwarzenegger vetoed this bill twice. He misrepresented it and said it was socialized medicine. It is not socialized medicine. That's not true. And so we need to fight for this bill, and we need to examine how it will be funded. There's been a lot of analysis done by very qualified people who don't work for the single-payer organizations. They're as objective as people can be, and it's been looked at a number of times, and it's been shown that it would actually save you money to have this bill. You would pay less for your health care than you're currently paying. You're paying in lots of different ways. You pay premiums, you pay co-payments and deductibles, you pay state income tax, you pay withholding tax at your place of employment, you pay Medicare taxes, and all of these streams of funding would go into the single-payer system. There's also a federal bill in Washington, which is the Conyers bill, H.R. 676, not going to go anywhere in the current Congress, but it's there, and if we had a different complexion in Congress, it might get some attention. So hopefully we'll get into some of the uncovered areas in the question and answer period. Thank you.
Thanks very much, Hank. Covered a lot of territory and gave us a lot to think about.